and the post ACS, DAPT or SAPT. Both, we have been having DAPT from last many years, and SAPT concept is now coming in a very small way. Still, one feels that when dual is there, why we should have single. But taking of medicines is a big job, and you have to take those medicines for a long time. So 1 year, 2 years, 3 years. So let us hear from him what he has to say on this. Please, Dr. Viveka. Thank you, sir.
Well, so good evening, friends, and again we are back to golden days.
Can we dim the lights, please? Hello? Can we
2
dim
years
the lights?
back. Can you hear me? So basically, as Dr. Chauhan and Dr. P K Gupta has said, that we are back to old ways of living, which we are used to. So basically, it's a end game of the COVID pandemic, most probably, and I would say that it's been really a big relief, and that even the government has started international flights. Probably the masks will become like an hanky, so we'll have to keep it in pocket, and then if somebody suspected infected person is coming, probably we might have to use, or for the purpose of not getting a challan from the police officer, we will be having it. And I must say that the kind of affection and kind of support we have got from the group, from each member of you, it's been really fantastic, and I must say that it's been one of the most trusted support I have had in my career. So special thanks to all members who have been here, and I would say that. So before I start, I must say that a big thank to all of you, and I hope I have justified your support. So let's go to the acute coronary syndrome. We know that it's one of the most dreaded disease to have, and the question of whether we need to give a true antiplatelet medication or single antiplatelet, it's something which is we need to think over it, because there is always a risk of balancing the risk of bleeding versus the risk of thrombosis. So it is the it's like our Supreme Court's that balancing wheel, where we need to see whether the bleeding risk is more or the thrombotic risk is more, and if the thrombotic risk is more, we go with extra mild and we give more antithrombotic agents. So if you see the antiplatelet therapy, pivotal role in acute coronary syndrome, or what we call post intervention patients. So antiplatelet has remained the cornerstone of treatment for patients with acute coronary syndrome, and platelet adhesion, activation and aggregation after plaque rupture or erosion are the major determinants of arterial thrombosis leading to acute coronary syndrome, which is antiplatelet therapy is vital. So we have seen not many patients who were already on antiplatelet treatment. There the complications and the size of infarct is significantly smaller when they are already on antiplatelet treatment compared to those who were not on that. Meaning thereby that antiplatelet treatment is a vital piece of a treatment strategy, and multiple and platelet signal pathways are involved in thrombus formation and are potential target for the therapy. So if we can inhibit the platelet in initial thrombus formation, then we have partially won the war against this thrombotic complication. And whether we need to have with aspirin any other P2Y12 receptor inhibitor, that is something which is the answer is absolutely yes, we need to have something. But now there are increasing evidence where is it time, if you see the recent JSCC journal and the circulation editorial, there is again whether we should pay approximately to aspirin, whether we should retire aspirin. So meaning thereby that the current potent antiplatelet therapies like ticagrelor and prasugrel, we don't really need aspirin, but we need really some more evidence in that direction. And we all know that the antiplatelet therapy, P2Y12 receptor antagonist, aspirin, was golden, old thing, but clopidogrel, prasugrel, ticagrelor and cangrelor. Now cangrelor is available in our country, so we've been using it in patients who have had, who are intubated, who had vomiting, who cannot take oral tablets. But again, the uses of antibodies like JP2B inhibitors and all, eptifibatide and tiotropium has come down significantly with the availability of potent antiplatelet drugs. So inhibition of platelet P2Y12 receptor, there is a differential, activation, and we know that P2Y12 receptor is very, very important in that direction. So if you look at the antiplatelet injection, it was presumed and understood that aspirin has to be there in the treatment algorithm, and then we had to choose. Ticlopidine was something which was before clopidogrel, so probably that's not something which we use. But when I started in cardiology my career in 1999 and 2000, that was the time when the ticagrelor was being used, ticlopidine was being used, but then the clopidogrel came, and then the things changed. Then the stent thrombosis, all those problems, went down significantly. And then when the ticagrelor and prasugrel came, it was really, golden era of intervention cardiology. GP2B inhibitors, the uses was much higher in clopidogrel and ticlopidine era. This is again an injectable antiplatelet agents. But then once we came into the era of ticagrelor and prasugrel, the uses became significantly low. And now we have got some more antiplatelet agents like Voraxapar, which has shown the superiority in dipyridamole and silestridol, which is more often used in peripheral vascular disease. But there has to be a balance between, because you can't really go on giving antiplatelet and antithrombotic agents because there will be increased bleeding risk. Other day, day before yesterday, I had a patient who had 74-year-old gentleman who we gave clopidogrel, and because there was large thrombus burden and GP2B inhibitor injection was given, and then he had a cerebral bleed. So we need to always balance the things that if the bleeding risk is more, then we should be very cautious in antiplatelets so that the bleeding does not happen. And if the GI bleed is there, still you can manage with the blood transfusion and all. But if the patient gets cerebral bleed, then it's a catastrophic complication. So we need to look at, and we'll come back later on that whether we can do the what we call bleeding or risk calculation, whether the patient has got high risk of bleeding or whether the patient is having high risk of thrombosis. And if the risk of thrombosis is more, we can go on more antiplatelets and more antithrombotic. And if the risk of bleeding is more, what we call HBR, that is high bleeding risk things. So now the current generation stents are there where we can de-escalate the dual antiplatelet to single antiplatelet after 4 weeks of treatment. So just 3-4 days back, I treated one lady who was 78 years old lady, and we had, she has localized CA of descending colon, and she had, anemia. And on workup, we found that she has hemoglobin of, repeated transfusions was required, and she wanted no surgical intervention, had got LAD and circumflex lesion, and we treated that, and she is waiting for resection. So PET scan shows that there is no dissemination, so she will be getting the treatment, resection of descending colon in 4 weeks time. So now with the current regime, we can offer her that, after angioplasty, she can get the, surgery done. So aspirin for secondary prevention, we know that the prior myocardial infarction, acute MI, prior stroke, the guidelines says that, we need to, the trials are so robust that, there are 12, 15, 21 trials in that direction, and that shows that definitely the odds of reduction of repeat event are significant, almost 25 to 30% of risk reduction is there. So definitely these the patient we need to give them antiplatelets so that the repeat events are lesser. So 10 to 20% of aspirin treated patient experience a recurrent vascular event within 5 years. So definitely we need to top it up with another, P2Y12 inhibitor, and possibility of aspirin, variability of response in 5 to 60% of aspirin treated patients are there. So clopidogrel plus aspirin reduces the risk of thrombosis, and we have got the data from Cure, PCI, Credo, Clarity, Commit, and Charisma trial, and all of them, put together would be nearly 25 to 30,000 patient data, and that clearly shows that the event rate, if you put them together, is significantly lower when you compare it with the placebo. So dual antiplatelet in acute coronary syndrome is definitely the answer, and if you look at the current guidelines, we need to combine aspirin with clopidogrel, load with 600 milligram of clopidogrel or 60 milligram of prasugrel or 180 milligram of ticagrelor, and continue it for 1 year. And these data, prasugrel data is from Triathlon Teaming 38 data, ticagrelor from Plato data, and then the clopidogrel is again from current Oasis data. So all of them have shown that in patients who have got acute coronary syndrome, or the patient who were stented or bypass surgery was done, dual antiplatelet was the name of the game. So if you give it, the risk reduction of thrombotic complication was significantly lower. So chronic aspirin therapy doses and vascular event in high-risk patients. So there was a data to show whether we need to give 500 milligrams or 325 milligrams or 150 milligrams or 75 milligrams, or even the any aspirin dose, so 75 milligram or anything, it saves the patients from any complications. So you can see the odds ratio as antiplatelet was better compared to the aspirin, antiplatelet was definitely odds ratio was in favor of the aspirin therapy. The aspirin dosing in patient treated with DAPT, you can see the recommendation is loud and clear that at least 81 milligram of aspirin is recommended to prevent any complications. So if you look at the pharmacological properties of antiplatelet, and we have options of clopidogrel, prasugrel, ticagrelor, and cangrelor is intravenous. So if you see that all the oral agents, there is the faster acting agent is the ticagrelor. So these are the agents which have shown to decrease the thrombotic complication, and that is why they are there. So if you see the current practice is limited to clopidogrel, prasugrel, and ticagrelor, and these are the agents which we have been using by and large. If you see the prasugrel, which has got a longer duration of action, the ticagrelor has got duration of action on just 72 hours. So that is why it is much more preferred. And if you see the different trials to support that, so there are landmark trials for antiplatelet therapy, and right from the ISIS-2 for the aspirin, caprin, clopidogrel, and the Credo trial, which was again with clopidogrel. We had last trial which on TV38. Plato, Triology, Champix is with Calcitrol, which is an injectable. So there are a lot of patients who are not on antiplatelet and have come with acute myocardial infarction. So in those situations, we try to use Cangrelor and Voruxapar, which is an agent which has a lot of promise, but we have not. It's not really available in our country, so we don't. So let's look at the guideline. What to do say? Definitely, if you see that the patient who has had an acute coronary syndrome, in 2017 ESC focused update on dual antiplatelet therapy in coronary artery disease, developed in collaboration with the ESCT, that clearly shows that clopidogrel should be used in 600 milligram and 70 milligram once a day doses in patients with acute, STEMI patients, that is those who have got acute ST elevation myocardial infarction. But ticagrelor and prasugrel on top of aspirin may be considered instead of clopidogrel in patients who have got acute coronary syndrome. But definitely these are the agents which should not be used in management of stable coronary artery disease. So the recommendations have really changed over the time. Prasugrel should not be administered to patients with prior history of stroke or TIA because the risk of bleeding is significantly higher. So, but in acute coronary syndrome where you have already committed for primary PTCA, the prasugrel is a good agent, and definitely in patients who have stent thrombosis it could be used. So ticagrelor we need to load with 180 milligram, prasugrel with 60 milligram, and clopidogrel we need to load with 3. Those who are already taking 75 milligram once a day, we can give them loading dose of 300 milligrams. But those who are naive patients, we can give 600 milligrams of loading with the clopidogrel. So if you look at the guidelines, again in acute coronary syndrome, whether we are using drug-eluting stents or bare stents, we need to, there is we can go to the newer agents and give, so especially ticagrelor and prasugrel can be used in these situations. So if you see the 2014 ACCHA non-stress elevation ACS guidelines, again it's reasonable to use ticagrelor in prevalence of clopidogrel, but if you look at the recent data that in acute coronary syndrome and acute mitral infarction, definitely the ticagrelor and prasugrel are the preferred choices compared to the clopidogrel. But beyond that, after 3 years, 3 months, you can see that the clopidogrel could be safer, the risk of bleeding could be lesser. So that is why it is much better, and it is more economical because it is out of the patent law, so that the cost effectiveness of this is much better. So if you look at the PCI for ST elevation or non-ST elevation MI, the guideline still continues to say that the dual antiplatelet for 1 year, and you can use either ticagrelor, prasugrel with aspirin, or even clopidogrel. But the reason with the clopidogrel was that the clopidogrel resistance is significantly higher, so we need to use it, in initial few months we should be using ticagrelor or prasugrel. And if the risk of bleeding is there more, then we need to change to clopidogrel rather than the prasugrel, because so we need to always look at the what we call bleeding risk scores. So we'll come to that. So elective PCI, not at high risk of bleeding, dual antiplatelet for 6 months. So if you look at not only there is a revolution in antiplatelet treatment, but also there is a revolution in the stent technology. So the current generation, what we call third generation of stents, they are very good. The stent strut thickness is less. So these stents, even a lot of stents data is that even 3 months of dual antiplatelet is good enough, and then you can switch back to one single antiplatelet. But if the patient thrombotic risk is high, you can even go to 3 years of dual antiplatelet. So in India, because even the Sun Pharma has got the Rosuvac and other combinations which are cost effective. So in high bleeding risk, you can go for dual antiplatelet for more than 1 year, so that the risk of thrombotic risk is significantly lesser. And if you see the MACE and mortality reduction significantly, there is a MACE and mortality reduction is also there. So let's look at the different trials with single antiplatelet and dual antiplatelet. So if you look at the CAPRI, Charisma, Pegasus, and TB50 trials. So Pegasus and Charisma, these are the trials which stand out, and that really shows that beyond 1 year, if the patient has got multiple stents, diabetic, chronic renal disease, and risk or longer stents more than 20 millimeter, then there it is worthwhile to give dual antiplatelet for longer than 1 year, so that the risk of thrombotic complications are lesser. So we have got data from PCI Cure, Triton TB trial, Plato trial, and Triology ACS trial, which clearly shows that large variation in IPA response is there, requirement for metabolic activation is there, there is suboptimal onset of action for acute setting, irreversible P2Y2 receptor binding, and raised risk of bleeding by increasing the inhibition of the platelet activation. So we need to come to a balanced level where the risk of bleeding is significantly lesser. So there was a trial with ticagrelor, reduced dose, not 90 milligram, but 60 milligram of ticagrelor twice a day, and they compared the data from 7,000 patients in each arm, placebo, 60 milligram of ticagrelor, and 90 milligram of ticagrelor. So it clearly showed that patients who were after 1 year, you de-escalate the therapy to 60 milligram twice a day, and then give it for almost 33 months, and there it showed the risk of composite of cardiovascular death, MI or stroke was significantly lesser. So the Pegasus trial showed that there was a 15% risk reduction in the primary endpoint for 90 milligram, and 60 milligram there was 16% reduction. simply because with the lower dose, the risk of bleeding was significantly lower. But this story is after 1 year. So from 1 year to 3 years, you can give this dose. So Pegasus trial clearly showed that the cardiovascular death and the reduction in myocardial infarction and stroke, according to the experimental analysis, that clearly showed that we are justified in high risk patients. Those who have got thrombotic risk is high. Where so who are the patients who have got thrombotic risk high? Those patients who have got multiple stent length is more than 20 millimeters length, and those who have got diabetes, chronic kidney disease, and all. So there we should be using it. If you look at the consistency of cardiovascular benefit over 3 years, definitely the first year in trial there was a 18% risk reduction in hazard ratio. Second year in trial 10% reduction, and third year in trial 23% reduction. And remember, it's not that the risk of stent thrombosis was more. It was in non-treated patient, the arteries where there was borderline blockages. There the thrombotic risk reduction was primarily driven by because of that. So definitely, if you have longer than 1 year, we state that dual antiplatelet in high risk group, the risk of the thrombotic complication are significantly lower. So choosing who should be considered for prolonged DAPT, so the factor associated with increased ischemic and bleeding risk. So we see that we need to, so what we call horses for the courses. So we need to have patients who have got at a high risk of thrombosis and the patient who have high, what we call SBR risk. So the patient who are elderly, those who have got risk of bleeding, those who have got a previous TIAs and strokes, there the risk of CVS and all bleeding risk is high. So there we need to be really careful. So then there was a risk score calculator which came, and that is something which is important. So we need to find out whether the patient is falling in the high bleeding risk. So now there are a lot of stents, the current generation stent, where we can do away with the dual antiplatelet after 1 month, but definitely after 6 months. Most of these stents have got certificates to stop DAPT after 3 months. But those who have got acute coronary syndrome and high risk of thrombotic complication, there we can extend the DAPT beyond 1 year and go up to 3 years. Now we have got dual pathway inhibition, also what we call the antiplatelet plus antithrombotic agents, where the rivaroxaban 2.5 milligram in coronary dose can also be given. So the clinical and procedural risk factors associated with increased ischemic risk or increased bleeding risk. So we need to look at the factors which increase the risk of stent thrombosis. So patients who have got acute coronary syndrome, patients who have got diabetes, those who have got low ejection fraction, those who have had an older generation of stent undersizing, so not a good angioplasty, bifurcation and stent restenosis. These are the risk for problem. But those who have increased risk of ischemic risk, multiple myocardial infarction, extensive coronary artery disease, patients who have got CKD, diabetes and all these. So the balance has to be there so that we can triage our patient on which path the patient has to go. So if you see the risk score, so there we say higher the age, the more risk of bleeding. So age 65 to 75, -1 point is given. Age 75 or more, -2 is given. Because the higher the age, the more the risk of bleeding. But if the patient is smoker, then 1+, diabetes, again a risk, myocardial infarction and presentation, again one risk. Stent diameter, if you have given a smaller stent, then we need to give 1+. If the patient is on paclitaxel exclusion stent, which we no longer use it, then again, if the EF is low, less than 30%, then again the risk is high. And if the patient has got graft angioplasty, because post bypass graft, especially the venous graft, then again the risk of stent thrombosis is there. So we need to always so if the DAPT risk is less than 2, then we are justified in giving single antiplatelet, or if it is higher than 2 or equal to that, then we have to have more antiplatelet. But I would always say that when I was in UK and Keith Dawkins was president of British Intervention Society, so he used to say that if you haven't done a good angioplasty, no amount of antiplatelet and the antithrombotic agent is going to save it. So you need to do a good job at least during intervention. So AF and elective PCI, which is very common because they are doing in elderly patients, but if you give the triple therapy, then the risk of bleeding is significantly higher. So we need to triage our patients. So acute coronary syndrome, patient has got atrial fibrillation. In those situations, we know from West trial that if you give triple antiplatelet therapy, 2 antiplatelet and 1 warfarin, the risk of bleeding would be significantly higher. But to decrease the risk of stroke, you need to give the antiplatelet, anti-thrombotic and antiplatelet. So there are a lot of data which came like Augustus trial and all that showed that you can do away with the triple antiplatelet, triple therapy. You can give one antiplatelet, that is clopidogrel, and you can give the newer anticoagulant so that the risk of bleeding is significantly lower. So if you look at the summary of recommendation for concomitant antiplatelet treatment with oral anticoagulant as placement, it shows that 4 weeks of stable coronary artery disease undergoing PCI, we can do antiplatelet and newer oral anticoagulant because the risk of bleeding is significantly higher with vitamin K antagonists like warfarin and acetone. But if you give the newer anticoagulant like rivaroxaban, or if you give the apixaban, the risk of bleeding is significantly higher, the lesser. So we should switch this patient to the newer oral anticoagulant and then give clopidogrel only. And after 1 year, you need only newer anticoagulant. You don't need to give them antiplatelet at all. The secondary prevention of the patient with coronary artery disease, again the P2Y12 receptor inhibitor therapy for secondary prevention of patients with coronary artery disease. And the gist of this busy slide is that despite the large body of randomized evidence, the optimal regime and duration of DAPT for secondary prevention of patients with coronary artery disease remains a matter of intense debate, and that's really true. But if you see, we don't really use any bare metal stents now. We have got, because government policy and all, there's hardly, price difference and all those things are not there. So we have been using almost 99% patients with the, the drug-eluting stents. So if you see P2Y12 receptor inhibitor therapy for secondary prevention of patients with acute coronary syndrome, the still up to 6 months is mandatory. We should be giving dual antiplatelet therapy. But discontinuation after 3 to 6 months may be considered in patients who have got HBR, that is high bleeding risk. So sometimes the patient is on one antiplatelet and is not suiting. Suppose the patient was on clopidogrel and had stent thrombosis, he would like to switch to ticagrelor or prasugrel, or the patient had breathing difficulty. One of the side effects of ticagrelor is the patient would have breathing difficulty, so you would like to shift to prasugrel. So you need to reload the patient with the full dose of newer antiplatelet which you are shifting to. So that is what the shift trial showed. And in these situations, we can, go to newer antiplatelet, fully loaded, because there cannot be more than 100% inhibition of the platelet. So even if the patient is fully loaded with clopidogrel, you can reload with the ticagrelor or prasugrel and take him for, intervention or switch the patient to other patient. Intensification strategies, as I said, that the patient who had an adverse event with clopidogrel, you should go to the next generation antiplatelet, either ticagrelor or prasugrel, and you can continue with aspirin. So dual antiplatelet will be good. Perioperative management of antiplatelet therapy, because there are a lot of patients after intervention they will need some other surgeries. In those situations, now you cannot stop aspirin unless it is an intra-arterial bleed. So the patient has to be cleared on at least 75 mg of aspirin. Those who have got patients who really need surgery, we say that after 4 weeks the patient can be brought down to single antiplatelet aspirin and they can get operated, but don't take both the antiplatelet. Aspirin for primary prevention of the atherosclerotic cardiovascular disease. So the guidelines, more than 5,000 patient data has shown that clearly we need to look at least the person has to have more than 2 risk factors to have more coronary artery disease problem. If it is not, then the benefit given by aspirin as a primary prevention outweighs the risk of bleeding, so you don't get any extra benefit. So don't take aspirin if you do not have diabetes, previous coronary artery disease, or CT coronary angiogram shows plaques and all. So I think to conclude, I would say, friends, ladies and gentlemen, that as antiplatelet treatment is the cornerstone of treatment of coronary artery disease. Acute coronary syndrome is most lethal form of presentation of coronary artery disease, and we need to definitely give dual antiplatelet, and we should be shifting in the direction of dual antiplatelet with a newer agent to prevent a thrombotic complication. And if there is a patient who has got atrial fibrillation, we don't have to give triple therapy. We can give one newer anticoagulant with clopidogrel, and after 1 year of ACS, we don't need to give antiplatelet at all. The anticoagulation therapy, newer anticoagulant would do the job. So I think that's all which I have to say. And thank you once again, and it's been really great. Thank you once again. If there is any question, I'll be more than happy to answer. And over to Dr. P K.
Can I have the mic, please? Yeah.
Thank you very much, Dr. Viveka, for your magic touch with the lecture. And in very short, you have explained the role of DAPT and SAPT. Still, DAPT remains the mainstay of therapy, and SAPT has to be given in some cases. So, the floor is open. You are welcome to ask questions. Be brief in your questions.
Thank you, Dr. P K. Dr. Viveka, what a nice talk, sir, once again. Okay, sir. So, as P K said, most international practice guidelines had recommended the use of DAPT for at least a year and maybe beyond. So, as the ACC, AHA and the ESC revised the guidelines, now as a new paradigm has been introduced, DAPT and SAPT. Sir.
Yes, I think that's a very good question. So you see, at one hand, we are saying that we need to extend the duration of dual
Can we have some silence at the back, please?
and at the same time, we are saying that we should be moving in direction of single antiplatelet. So that there the question comes that we need to individualize the treatment. So those patients who are at a higher risk of bleeding, there should not be one rule for everybody. So suppose you have given a stent to a obtuse marginal branch or diagonal branch. So the risk-benefit ratio of giving him dual antiplatelet does not justify for 1 year or more than 1 year especially. So I think we need to individualize, and that is why the DAPT score comes very handy. So guidelines are coming up and they are saying that we need to individualize, we need to categorize our patient in that score, and if the patient's thrombotic risk is high, means that they have got more than 3 stents or equal to 3 stents, they have got longer stents, more than 20 millimeter, then probably we are justified in longer stents. Those who are not elderly, dual antiplatelet for longer than 1 year is justified. But those who are high bleeding risk, we have got now stents and data which clearly shows that if you see the biofreedom trial, the Onyx 1 trial, that all shows that even the synergy trial, that shows that after 1 month, if we come back to single antiplatelet, then the risk of bleeding is significant. The distant thrombosis is not that high. Having said that, we need to always look at the thrombotic risk and the bleeding risk, and that is where the whole crux of the matter is. And guidelines always say that the guidelines are a broad, practicing algorithm, but we need to choose our patients and then give their treatment as per the requirement.
Very well said, sir. So guidelines upside down, which P2 by 12 inhibitor depends on the ischemic risk and the bleeding. So stratification tools into action now. Hence the need for personalized, as you said, antiplatelet therapy. Clopi versus Tika versus Presu. So would it depend on the ischemic burden and the risk of bleeding? What do you say, sir?
Yeah, so I think
Just a minute, sir. We are again having a lot of disturbance at the back. We can't hear.
We would request to maintain the decorum as per the physical meeting, not the virtual meeting.
That's it. That's it.
So I think Dr. Chauhan, if you could come in front and take the responsibility. Tulsi doesn't get offended.
Dr. Chauhan, can I request the people at the back to come in the front?
Dr. Tulsi, if you look at the reality, those who are in back, they are really in front because that's the door.
Yes,
area.
yes.
Sir,
Let him answer.
sir, the one on the back is a supporter of Akhilesh and is saying there is a problem with the ABM.
Okay, sir, please answer the question. Floppy versus Prasu versus Ticket.
Yes, so obviously if you look at the data, that is very loud and clear that when the acute coronary syndrome is there or when the stent has been implanted or even the bypass has been done, first 3 months is the most crucial. And obviously the whole saga started with 1 year, then 6 months, and now it has come back to, if you look at the trial, twilight trial and all that has clearly shown that the first 3 months is the most crucial period where you need to give your best antiplatelet. So definitely the ticagrelor plus aspirin is the answer in first 3 months. So I would say that those who have had stent thrombosis and other adverse complications on clopidogrel or ticagrelor, then the prasugrel will be the best choice. In younger patients where the thrombotic risk is high or you have committed, so if you see the trial which has shown that we should not be loading patients with prasugrel before the angiogram is done. So prasugrel is has got a niche indications where the thrombotic risk is very high, then we should be using prasugrel, otherwise the ticagrelor is the norm. But if the patient has had, if the patient is falling in high bleeding risk group, then we need to, de-escalate the patient to, after 1 month, to single antiplatelet. In fact, there are trials which is going on with single antiplatelet with the newer agents like ticagrelor and prasugrel, where you don't give them aspirin at all. And now, if you must have seen the editorial that is it time to say goodbye to aspirin. So definitely these agents, so what I understand and my feeling is that probably when you are using ticagrelor and prasugrel, we don't really need to use aspirin because that unnecessarily increases the risk of bleeding without giving you a significant advantage of thrombotic risk. So I would say that as of now, as the guideline says, first 3 months you must give dual antiplatelet with ticagrelor or prasugrel with aspirin. As far as the doses of aspirin is concerned, anything 81 milligram is good enough with ticagrelor. For prasugrel, the data, because there is not much trial, it is only 150 milligrams, so we should be giving aspirin 150 milligrams. But beyond that, I think very soon we will be seeing end of aspirin era.
Well said, sir. So, Indian Academy of Neurology just last month published an article saying the resistance to clop is as high as 64.5%. And at least 1/3 of the patients on antiplatelets had strokes, ischemic strokes. So, your word on that?
Yeah, so that's a very good, so in our experience also, and we had also published the data of clopidogrel resistance. And in fact, before ticagrelor and prasugrel had come, we had different registries where we showed that almost 25 to 30% resistance with clopidogrel. So it's very, very uncommon in today's time to see patients coming with stent thrombosis and all, unless the patient has discontinued the treatment completely. And even, you'll be surprised to know that there are many patients who are off all antiplatelets with the newer current generation generation stent. The risk of stent thrombosis is not really high. So I would say that the two technologies moving together, the robust antiplatelet and better stent technologies. Now the strut thickness has come down to 60 microns. So there's hardly much surface. If you look at the stent coverage of the vascular imprint area, that has come down significantly. So risk of stent thrombosis has come down significantly less. So unless your vessels are really small or you have multiple other risk factors like smoking, diabetes, chronic renal disease and so on and so forth, it's really very uncommon to find stent thrombosis.
My last 2 questions, sir. So regarding the drug-eluting stents, so what do you expect in the 5th generation stents? Probably polymer-free and absolutely ultra-thin struts. What do you say, sir?
Yes, I think we are now using, there are a couple of stents from Germany we have received. I used SAPT stents where there is no polymer just the drug, and the stent strut thickness is 64 microns, so that would be the real answer. But we need to again balance the, good stent strut should be good enough to give the radial strength. So you are right that probably in the improvement, after the improvement in the stent strut and the technology, probably the dual antiplatelet treatment cannot be required as much as we have been using it now.
So my last question, Dr. Viveka, would be, is thrombosis the only thing? See, the inflammation, the hemodynamics, and the vascular tone probably also plays a part in ACS. So probably need to combine drugs like rosuvastatin and all to reduce the inflammation.
Yes, I think one of the things which we learned in the COVID pandemic is that inflammation is the crux of all major vascular diseases. I've seen 21, 22 years old females, not of males, females who have had no active smoking, nothing, but they had COVID and they came with triple vessel disease, acute coronary syndrome, stent thrombosis, and interliquids were high, sky high. So I would say that inflammation of any nature is the root cause. So if you look at the inflammation, that is how we determine the vascular age. So I always say that a lot of patients who come to me and say that can we, get away from these medications and all. I said only one way, that if you become younger. When we say you become younger, it means that your vascular age comes lower. It means that your inflammatory markers has to be low, your pollution level, all these, the CRP level and all those things has to come down. So inflammatory marker, if it is low, then probably the coronary artery disease will be lesser. So if you see why Indians are getting more and more coronary artery disease, because we are exposed to so many inflammatory diet, inflammatory lifestyle, inflammatory environment and all. So probably that would be contributing. So the inflammatory less environment will bring it down.
Thank you, sir.
Sir, after exhaustive questions by Dr. Tulsi, sir, firstly, let me welcome the Boni. Boni is the welcome start. Punjabis know. Boni, Boni कहते हैं to start होते हैं तो Boni, sir. So your Boni is welcome, and we always relish, and I wish you to be what we call it, carry through the innings, start and end of the innings.
Carrying the bat.
Yeah. So you carry through the bat, sir. So you have started the first CME with us, and with the end of session in the year, I wish you will be the last to carry and not out, sir. 175 not out. Sir, Dr. Chauhan had mentioned something about happily married thereafter. So there are people who are happily unmarried also. Sir, even if married or unmarried, we are happy with you. Does it matter whether anticoagulants are also being given due to whatever other reasons may be here or whatever? The choice of single or dual antiplatelet, will it matter? And will the duration be modified because antiplatelet is going on? Please.
Yeah, so I think that's a very good question, and that is my favorite,
Sir, good question on marriage or being happy family after that.
Sir, पति पत्नी और वो antiplatelet and dual. So वो है ना तीन हो गए.
Please.
So first of all, this question of dual inhibition, so antiplatelet and anticoagulation. So that is to my mind, would be the future, because if you look at the champion trial, that Rivaroxaban plus aspirin, low dose aspirin, has shown to decrease the overall thrombotic complications significantly. There was 70% reduction in amputation in peripheral vascular disease. Somehow it has not yet come in guidelines, but I would say that that will be the future. So you are very right that one antiplatelet and one newer oral anticoagulant would be the answer to this, and that would solve, because when you are hitting the antiplatelet and antithrombotic dual pathway, so the risk of acute thrombus formation will be significant. significantly lesser. So if you look at the history of acute myocardial infarction, the treatment at one point in time was only warfarin, because people, 1985 it was found that the clot formation in the autopsy trial data did show that the clot in the coronary artery disease causes, acute myocardial infarction. And the patients who were on warfarin for a couple of years, the risk of recurrent MI was significantly lower. But the problem with warfarin is that, you need to check the INR and all those things. But the newer anticoagulant in coronary dose, that problem will go away. So I think you are very right, that is a futuristic idea. But as far as the, happily married if ever after or happily unmarried, that is Dr. Chauhan is expert on that, so I'll invite his comment.
So my next question is just to clear our doubt of the whole forum. Is very curious to know how many days before any procedure should the dual antiplatelet or whatever should be the changes stop.
Yeah, so
Before the procedure, and especially the dental, because they are very common.
So that's a very good question. So if you see the longer the duration of action, so prasugrel we need to stop for 7 days, ticagrelor 72 hours, clopidogrel 5 days, and aspirin at all they have to stop again 5 days. So now most of the surgeries, even the dental extraction, they do it on aspirin 75 milligrams once a day. So I think that is how, if you are using newer anticoagulants, the guideline is up to, at least 24 hours should be given for.
In the slide there was shown that paclitaxel was number 1 plus. So does it mean that paclitaxel eluting stents, so are they minus point?
Yeah, so paclitaxel is an inferior stent compared to sirolimus or everolimus or tacrolimus. So all these, so paclitaxel, that is why no newer generation stents are coming with paclitaxel. So that's a minus point, you're right.
Dr. Viveka, so commonest site of bleeding on dual antiplatelet, is it GI tract or cerebrum or something else?
No, so obviously the subcutaneous and subconjunctival is the commonest site, but the GI is next and the cerebral is the least common.
Suppose a patient has undergone angioplasty and he is on dual antiplatelet, and after 4 weeks he needs emergency appendectomy. So which antiplatelet should be stopped, which should be continued?
No, so just give him aspirin. You can stop clopidogrel or ticagrelor or prasugrel, whatever he's taking, and he can be operated. So current generation stents, as I said, they are very forgiving. So if you can just on aspirin, and that too, on day of surgery, you can stop aspirin and then restart after the surgery.
The concerned cardiologist should be consulted before that?
Obviously, because the domain of stopping and all, the cardiologists are very clever, so they have kept things in their hand. So unless the surgical clearance and also, I know a lot of cardiologists who earn more than the interventional cardiologists by just giving the clearance and standing in OT.
Thank you.
Thank you. Dr. Mangla want to ask.
Besides aspirin, others should be stopped.
Yes.
If it is emergency.
Yeah.
Dr. Mangla, please ask. Surely.
Actually, for some reason, the patients in ICU are given Clexane or low molecular weight heparins. Maybe single dose prophylaxis or therapeutic for some reason. And if these patients are on dual antiplatelets, do you need to make some changes? That is number one. Number two is because these post-COVID patients, there is an incidence of sudden cardiac death. Most of them, if they are having ischemic strokes, they may be having thrombosis of the artery. But is there a role of antiplatelets in this post-COVID event?
There are two very good questions. I would say that if you look at the data, that clearly shows that the on-dual antiplatelet giving subcutaneous low molecular heparin has not really increased the risk of complications. So statistically, it's not significant if it is being given for valid reasons. So we don't really need to de-escalate the antiplatelet or single antiplatelet. So if there is an indication, absolute indication for dual antiplatelet, so the patient who has had a stent recently, those patients who have got acute myocardial infarction and these things, or deep vein thrombosis along with these stents, then you can give dual antiplatelet plus the low molecular heparin together. So there's no harm in that. the risk of bleeding, because low molecular heparin and all is being given for shorter duration, so there is no problem whatsoever. The risk of bleeding is not significantly high. Coming to the post-COVID situation, it has been seen that it is better served with the newer anticoagulants rather than with the antiplatelets. So those patients who have got high interleukin, those who have got high D-dimer and all, they are better off with the NOACs rather than the antiplatelets.
It is primarily preventing thromboembolism, or is it helping in the coronary also?
No, it is for pan-vascular complications. So not only coronary but also the pulmonary and the DVT also.
Dr. Mathur, please.
Sir, thank you very much for a nice talk and starting the session again. We are very thankful to you for everything you did. A small question. Post angioplasty, say about 20 years back, somebody has gone through that, bare metal stent. And being on single platelet, there is equosprin for so many years. How long do we continue or should it be stopped? No other comorbidities and no other.
So I think that's a good question. So the answer as of now is that it has to be continued forever unless the risk of aspirin outweighs the risk of bleeding. So suppose somebody gets some other bleeding risk, then only you have to stop. So if somebody has got a stent or bypass surgery or the vascular event or thrombotic stroke, they have to be on lifelong single antiplatelet unless the benefit of antiplatelet is outweighed by the increase in bleeding risk.
Thank you, sir. Single antiplatelet is the more standard or most.
And then, sometimes we say that, you don't, because the action of duration of aspirin or clopidogrel is for almost 5 to 7 days. Then even in, as the age advances, you can make it alternate day or once in 2 days, something like that, depending on the cyanotic patches and all. But definitely it has to be there at least one antiplatelet.
The advanced age starts at what level? Advanced age starts at 75 or 80 or above.
So I have shown the data that the risk of bleeding, so if you see 65 to 75 is -1 score in DAPT and 75 plus is -2. So I would say 75.